Good evening, everybody. My name is Marushka. I am from Zavan Technologies, the manufacturer of the StimPod NMS 460, and healthcare company requested a webinar for us to share a little bit more about how this product works. So it is my pleasure to introduce to you the speaker of tonight, Professor Phyllis Berger. She's our clinical advisor and specialist. She's a physio and acupuncturist who's been involved with this product since 2009. She has also published more than 5 publications on this topic, and she's a lecturer at the University of the Witwatersrand in South Africa. So with no further ado, I'm going to present to you our speaker, Professor Phyllis Berger. I just want to mention that you're most welcome to pose your questions in the public chat area, and we will handle it in a Q&A session afterwards. Thank you very much.
May I carry on? Can you hear me?
Yes, Phyllis, you can continue.
Okay. Well, good evening, everybody, and it's really a great pleasure to be here to share my experience with StimPod with you. I just put up on the screen a little trophy that I received when I came to Hong Kong in 2005, and it was on acupuncture for physical therapists and on pain management. And it's very nice to connect with Hong Kong again. So I just wanted to mention that. Now, I've been asked to go through various topics, and I won't go through them now, but as we get to each one, you'll see which topics we are going to discuss. So the first one, the biophysical and technical background of StimPod, includes nerve locating technology and measurement of treatment progress. So here we have a handheld device with an unusual probe, a nerve mapping probe that assists with nerve location and delivers the RF waveform, which is the radio frequency waveform. The probe actually targets the nerve via the tip of the probe and easily identifies the nerve and results in fasciculations along this nerve pathway. And you can evaluate treatment progress by observing the intensity reached, but we're going to go into that later. You can actually treat any aberrant nerve condition with this device, and it produces a current of 133,000 hertz with a radio wave frequency. The waveform actually creates an electromagnetic effect, which is a magnetic field similar to what we see in invasive pulsed radio frequency. So the non-invasive pulsed radio frequency current travels to the dorsal root ganglion of the segmental nerve in the area to be lesioned, where if you use interventional pulsed radio frequency at the DRES, rhizotomy, or pulsed radio frequency procedure. But the NIPRF blocks the aberrant nerve conduction at the site centrally. For example, lumbar radiculopathy. It can also, this is the area that it would block for lumbar radiculopathy. It can also block the nerve peripherally. For instance, if you've got a nerve from a peroneal nerve injury and it creates lateral ankle or foot pain, you can also treat it with the StimPod, because being non-invasive, you can actually access any area in the body that you want to that's got a nerve supply. And your clinical results will provide observable and immediate proof of treatment effect. The interventional pulsed radio frequency usually is a medial branch block of the primary dorsal ramus in this region of a spinal nerve or of another peripheral nerve. The next slide just shows us how the pathway from the periphery will travel all the way up to the dorsal root ganglion and then enter the spinal cord and then travel on up to the brain, and a reaction will occur in the brain which will mediate the pain in the region. So actually, when we are stimulating a nerve with the pulsed radio frequency device, we are actually treating the brain as well, and that is very important in pain. So what is this nerve locating technology? It's transcutaneous, it's non-invasive, and it's a patented waveform. It's actually a pulsed direct current, and here you can see a square wave. And this is the direct aspect of the current, being the square wave. Oh, sorry. What have I done here? Just need to get it back to the normal. Do that again. Oh, okay. Sorry. Oh dear. Oh, I see what I've just done. It's too sensitive. Okay. So with the pulse direct current, you're going to get a combined pulsed radio frequency waveform for your therapeutic effect, which is actually going to change the nerve. But with the square wave, we have bioelectric effects, which actually causes ionization and depolarization. And this is what helps us to locate the nerve. And it doesn't matter whether it's a sensory or a motor nerve. This aspect of the waveform has the capacity to actually find the nerve site. Both nerves will depolarize, whether, as I said, sensory or motor, and it activates an action potential. If the correct site is reached, then fasciculation will occur. But if you're slightly off the nerve, it will not occur, and you will not see any fasciculation. But you may also not see fasciculation even if you are on the nerve site, if the condition is very severe and the patient has a lot of pain. So the RF waveform actually has bioelectronic effects, and it's actually has got it's a sinus wave. You can see it's got a positive and a negative, and they equal each other out, and it travels on the top of the square wave. Now, the pulse width is 0.1 millisecond or 0.2 millisecond. And that's the only pulse width we have with this. And the pulse rate is like a tens type with an intermittent pulsing of 1, 2, 5, or 10 hertz. And the intensity goes from 1 to 30 milliamps. The stronger the intensity will increase fasciculation. But it also increases the strength of the direct current, which may not be so comfortable because I'm not sure if you're familiar, but direct current itself can be quite uncomfortable. So we have to go according to the comfort of the patient. The pulse rate, if it's made stronger, may also be slightly uncomfortable, but not as much as the direct current. There is no sensation from the RF component. So the effects of the current are a neuromodulation of sensory or motor nerves, which leads to neuroremodeling because you're going to get cell metabolism changes that occur in the cell. There was a study done to demonstrate in a rat model with interventional pulsed radio frequency that there is latent cellular activity, and the neuroscientists measure the expression of CFOS as an indirect marker of neuronal activity because it is often expressed when neurons fire action potentials. So upregulation of CFOS mRNA in a neuron actually indicates recent activity. So now I'm just showing you again the sinusoidal alternating current, which is sitting on top of the square wave. The therapeutic effect of the waveform actually has bioelectronic effects. It's postulated that the cellular activity changes the characteristics of the upregulated firing of the nerve to allow it to revert to normal function. And we believe that it could switch on the CFOS in the DRG, dorsal root ganglion. Now, what are the effects of interventional PRF? The CFOS is involved in the regulation of transcription of genes and may mediate long-term effects of growth factors and membrane depolarizing signals on neural activity. And this is expressed 7 days post-PRF. Also, you get activating transmission 3 factor, which promotes neurite growth. And this occurs 14 days post-PRF, primarily on the cell body. Very often, we see this quite immediately, but it's in conditions that seem to take longer, this may be the action that is actually taking place. So if we're looking at the effects of the current, really may it cause increased pain post-treatment. And this does depend on the condition. If there is pain after the treatment, it may be due to the changes in gene expression to correct aberrant nerve firing. As I just mentioned, someone with a very severe pain, the nerve supply may be so disturbed that it has increased pain before it improves. Very much like a neuroma. When a neuroma is removed, it's quite painful until it settles down, and this may be the issue. And pain and mobility can change with treatment immediately. You can see it immediately sometimes at your treatment. There's a change, or over 1 to 3 days, or it may take longer, and we're going to see that in various case studies. Usually, with most conditions, improvement or change occurs within 1 to 3 treatments. And I must say, since I've been treating patients since 2009, I kept seeing the same issue occur. 1 to 3 treatments seems to make a change in most patients. So we decided to do a study on diabetic pedal neuropathy, and we'll discuss that later. And you can see how we achieved our results. Now, discomfort post-treatment does not relate to any discomfort during the treatment unless you've got hyperesthesia or hyperalgesia present due to sensitization and changes in the A-beta fiber transmission, meaning that your C fibers and your A-delta fibers transmit pain. But when the nerve is so disturbed, the A-beta fiber changes in its activity. It's usually a mechanical fiber. It changes and it becomes hyperesthetic as well, and that may give pain. And I like to give you a solution to this. You should treat distantly, either proximal to the pain. Let's say the pain is in the foot, you treat in the hip joint or at the level of the femoral nerve. If the pain is distal, like let's say if you've got pain in your lumbar spine, you're going to treat the sciatic nerve in the glutes or the leg, and that might prevent you from irritating the nerve. It just depends on what situation you have and what you decide. But improvement means relief of pain, increased range of movement, which you wouldn't expect, and function. Oh, sorry. So I've given you a sort of generic treatment protocol for any dysfunctional nerve. So you're going to determine the type of condition, whether it's neuropathic, neurogenic, whether it's an injury, whether it's iatrogenic from surgery or any other condition. So if the pain is severe, select the relevant nerve site that supplies the area, whether it's spinal, plexus, nerve root, or branch. And I will say to you that your plexuses are your best friends because you can reach many nerves at once. Select from the nerve branch that is not in the affected area, for instance, sciatic nerve for L4-5. It will be a mixed nerve. And when we talk about mixed nerve, we do not mean the senses such as smell, hearing, taste, sight, or the autonomic nervous system, but all the others. And you will have sensory conditions of pain or symptoms and weakness, but you will not see nerve conduction changes. We have not analyzed this weakness, but I will tell you that you cannot find a fasciculation if you've got severe pain. But as your pain recedes, so the fasciculation comes up, and obviously the nerve has improved. So that's how you can tell that there's an improvement, but you'll also see it in function, but we'll see this later with the case histories. You may see a fasciculation. So a weak fasciculation indicates the nerve is not firing normally. You start with a low current intensity and increase only if comfortable for the patient. You might use 5 minutes, but sometimes 10 minutes, depending if the nerve is very sluggish and you see weak fasciculations or nil fasciculations at all. Then you may decide you're going to do 10 minutes on that one particular nerve. The stronger fasciculations indicate that the nerve is normalizing. If there's improvement in pain and sensation, proceed to a more direct area of nerve supply. You can go right onto the foot if there's no irritation. So repeat and progress will either continue, decrease temporarily, or resolve the condition with 1 to 3 treatments or more. And it doesn't matter if you start to see a change in the patient, you know this augurs well. This means that it will improve. And so it's okay to do more treatments, as many as you need, which aren't a great deal. There might be 6 or even 12 treatments if it's a severe case or the condition has been going on for a long time. Now, I will tell you that Rhizotherm, the company, advocates starting with a width of 0.1 millisecond, 2 hertz at 30 milliamps, because most patients can probably tolerate that. And then if they're very comfortable on that level, he says proceed to 0.2 milliseconds at 2 hertz and try to get to 15 plus milliamps, but that's when it might become uncomfortable. I must say that I usually go in for the kill myself personally and go for 0.2 milliseconds at 2 hertz. And I just go according to the patient. And about 15 milliamps is usually what we get with a normal nerve. And sometimes it drops. Even a normal nerve can fasciculate strongly at between 3 to 7 milliamps. Now, we've said we're going to treat the nerve supply that influences the area of the pain. How will we measure progress? Well, of course, in the normal way. You're going to take a VAS score, a level of pain, note the type of pain, observe the site of pain, and note, is the intensity needing to change within the first treatment? If you start seeing that you had to push the intensity up strongly to get your fasciculation, and all of a sudden the fasciculation is very strong, then you can drop your intensity unless the patient is quite comfortable and says, no, carry on with that. Ask your patient during the treatment, and this is very important, is the area of stimulation emulating the pain? They might say to you, oh, yes, that's the pain. So then you know you're on the right track. Post-treatment, does it change the pain? We ask the patient, has the pain changed? And very often they can't say yes, but they say, it feels lighter or it feels a little different. And then I go straight on to function. I'll say, right, well, can you make a fist now? And very often, even though the pain hasn't changed, they can. And then you can ask them, has something else changed? So to measure the intensity required to observe progress, you'll see weak or no fasciculations, and you push up your current to as high as you can, and you note it down. And as you see your stronger fasciculations occurring, you note that as well. And then as you go along next treatment, look and see where you got to with your last treatment with your intensity. And then you maybe can even start on that intensity or go slowly up to it and see what's happened. But you might find that your fasciculations are much stronger and you don't need to treat as strongly as you would have before, unless the patient is comfortable. It seems that the manufacturers believe that we should treat very strongly, but I do say to you that from experience, if a patient goes away with a lot of pain and becomes very painful afterwards, they may not want to continue. So it's better to be cautious than to be giving patients so strongly. But I'm giving you this advice from a clinical point of view. So now let's look at the difference between the 460 and other waveforms for neuropathy. I'm going to take the interventional one, and this presentation was given by Dr. Russell Roth with permission to use his diagrams. And if you look at at the oscillating or alternating current radiating out from the active tip of the needle, it's usually over 500,000 hertz, which is much higher than 133,000. And you note the current density. It can be continuous or it can be pulsed. If it's continuous, it's going to create a lot of heat. And you're going to get the heat coming out of that tip of that probe. And it's going to coagulate, ablate, damage, and it's used for very severe pain, but you will have damage to the tissue. But if you have it pulsed, there's not enough, there's enough time for the tissue to cool, and there's not much heat at all, and there's no damage or destruction. And it can be used anywhere, in fact, dorsal ganglion, disc, peripheral nerves, stellate ganglion, even joints, even nerves supplied to the joint. But the interesting thing here is that you're going to get, they discuss that there's a magnetic field that forms in this area here. Now, nobody knows when it's a pulsed, interventional pulsed radio frequency, whether it's the magnetic field that's doing the good. And that's what we are doing with our pulsed radio frequency. We are giving a magnetic. So you have, it's done with the pulsed radio frequency, which is interventional, is done with specialized needles and an expensive pulse generator. And it is successful in various neuropathic states. But it does sometimes need to be repeated, maybe even every few years or every few months until the nerve settles down. And the effect is mainly on pain fibers, the C unmyelinated and the A delta, and it's purported to switch on the CFOS gene. Now we are going to look and just see what the interventional pulsed radio frequency compares itself to the interventional one. Ours is a 5-minute treatment with immediate effects. It has 1 to 3 treatments for changes, which is very different to the aggressive interventional one. There are permanent changes brought about at dorsal root ganglion and dorsal horn, and obviously in the brain. It improves neuropraxias and promotes nerve regeneration. Now, not many pain-relieving treatments actually improve neuropraxias. They have a specific effect, relief of pain, but you don't see nerve regeneration as in neuropraxia. So that is different. The clinical application is it maps nerves, which is really good for us too. As physiotherapists, we're trying to find the nerve to detect damage in a nerve. And that helps us because if we can see that we need to push up the current very high, we know that we need to, that we realize that this nerve is not normal. Not necessarily nerve conduction normal, but not normal. It helps in tractable and chronic conditions, especially neuropathic pain, and it stimulates peripheral nerves responsible for pain. And it, as I say, increases nerve conduction. Now, let's have a look at a microcurrent because we're going to compare it with other currents. Microcurrents are usually very low frequency voltage and amperage, and they are they've got a biphasic waveform. If you can see, they have a waveform that's in the positive and the negative. They are both positive and negative. I changed this in my other slides. They are subliminal, and they facilitate aberrant endogenous bioelectric signals. So if the signal for the ATP in the stimulated tissue is not normal, it improves energy for repair. Now, a direct current is not bipolar. It can be a straight line, but ours is an interrupted direct current, which can be either positive or negative. It will still give you the same effect. It can be interrupted, or as I said, a straight line. It's always a square wave. It's a square wave in our situation. And it also, in other types of current, can have an exponential decay. So it'll go straight up and then it'll slip down, go straight up and slip down. But ours doesn't, because we carry the RF waveform on the square wave. Here, effects are bioelectric. Depolarization and action potential occurs, and ionization also. And it increases circulation. And the intensity is also low. It can be from 0.1 to 3 to 4 milliamps. But you can't go much higher than that because it's very unpleasant. A TENS is an alternating biphasic. There's no net ionic effect at the end of the impulse. It's mostly sinusoidal, but it's also got different shapes, but they equal each other out. And you can adjust the rate, pulse, and width. It stimulates sensory nerves to block pain signals locally, dorsal horn, and centrally. And it produces endorphins at different frequencies, some at 2 hertz, and that's endorphins, and enkephalins much higher at, say, 150 or 200 hertz. And if a spinal cord stimulator will produce a TENS frequency deep in the tissues, and it can go up to 600. Now I've put the actual frequency of the different currents. So a microcurrent is 0.1 to 1 hertz. That's why it's subliminal and you cannot feel it. A TENS current, as I said before, the one that we'd be using is 1 to 200 hertz. A direct current goes from 0 to 150 hertz. So it's also quite a high frequency in hertz, but it's not iontophoresis. Now, a faradic current would be 30 to 100 hertz, and a magnet would be different. It's in Gauss. A magnetic field, the one we use, is 133,000. A laser uses nanometers, which is 600 to 800 or 900 nanometers. The interferential is actually a TENS, which is delivered deep in the tissue, and a high frequency is about 10,000 hertz. I'm sorry this is so slow. So let's look at the advantages of NMS compared to limitations of other currents. Microcurrents only relieve hypersensitivity, but in some patients, and it may also increase pain in others. And there are no further effects from this treatment. There are different kinds of microcurrents. I won't go into that. All of the above is subliminal and usually has no sensation. Now, the limitations of high frequency, say 10,000 hertz, there are no evident effects on neuropathic pain except for pain relief in the inflamed region. It's an anti-inflammatory. It works on the immune system of the body. And it works either locally or centrally or both, depending where the electrodes are placed, usually spinally or on a limb, but the results are not immediate. There can be weeks before you see anything. And there may be improvement in strength, but only over considerable time with the use of the device. And direct currents, neuropathic pain conditions may be irritated by direct current because if the skin is sensitive, that would be very unpleasant. That's why I mentioned all the precautions as I did before. There are no immediate regenerative effects on nerve conduction with direct current normally. Limitations of acupuncture. Acupuncture cannot be relied upon to change neuropathic pain immediately. Many patients are afraid of needles, and many patients do not respond to acupuncture, specifically those with high anxiety. And the limitations of conventional interventional pulse radio frequency, there may not be immediate effects on neuropathic pain or symptoms. And this may be evidenced only after a few weeks post-procedure, as we mentioned. There may initially be local edema too, and scarring at the site of the above treatment, whether peripheral or central. And it may require ongoing treatment to control, but often not completely alleviate the pain. So with StimPod, this current is non-invasive and non-injurious. Complete resolution of pain conditions, specifically neuropathic pain, may occur after 3 or less treatments or more. Treatment time is short. Treatment may be given at a distance from the offending region, nerve root instead of nerve branch. That means at the joint, spinal facet joint. This treatment improves nerve conduction and relieves neuropraxia, as in Bell's palsy. The current may have restorative effects on other nerve conditions. And at this point in the use of NMS, there appears to be more possibilities than. We are gathering evidence all the time, and we do compare it to placebo treatments, but we must remember that patients and their conditions are all different. Stages of conditions and disease are different. You cannot refuse treatment to a patient that is suffering. If it was a cancer patient, it's difficult to do placebo. Pain is highly complex. It's also has psychosocial elements, and it can be also neurogenic conditions that cause it. So from the beginning of your use of NMS, you will see evidence demonstrated by your results. And the bottom line, the overriding factor is that treating the nervous system will change nerve conduction by improving pain and function in almost all conditions. I know that I've repeated myself, but I want you to understand the concept so that you know that when you go to treat your patient, you know exactly where to work. Now let's look at the research on non-interventional pulsed radio frequency. This research was done a long time ago, and it was used with large electrodes that were either placed on the skin or above the skin. And Ginsburg found in 1936 that ultra-short radio waves worked as a therapeutic agent. And other folks, such as Lombardo, found that you could treat decubitus ulcers. And he presented this at a symposium in 1959. Duran and his group found that electromagnetic fields on skin ulcers of venous origin in humans responded, and he did a double-blind study. And Vodovnik and Karber did a literature review on the treatment of chronic wounds by means of electric and magnetic fields. And that was published as well in 1992. And I can tell you from experience, if you've got a patient with a wound that is painful, you should treat on the wound, just above and below, so that you don't irritate, but you will get changes in the wound that are magnificent. Sometimes the wound disappears almost completely. And Al-Badawi and his group looked at the efficacy of pulsed radio frequency energy therapy in TMJ joint pain and dysfunction, and that was published in 2004. And Guo, Kabat, Nelson, and Eisenberg did a meta-analysis of clinical efficacy of pulsed radio frequency energy treatment generally. But as I remind you again, these were large electrodes. We are using a small probe which targets the nerve, even of the skin, to get results. So let's discuss this electrical pulsed radio frequency device that relieves pain and improves function in patients with pedal diabetic neuropathy. A single-blind randomized placebo-controlled trial was done. We started at the end of 2016, in December, in fact, and we completed it in August 2019. So it took us a long time. We did a randomized single-blind placebo study, and we conducted it on 80 patients with pedal diabetic peripheral neuropathy in 2 cities and their surrounds in South Africa to determine if a pulsed radio frequency current can produce changes in the primary outcome of the DN4 test and possibly in the brief pain inventory short form test. So patients were selected by their physicians at Centers for Diabetes and randomized into the 2 groups, 40 patients each in the groups, A in the active, B in the placebo. The inclusion criteria were pedal diabetic neuropathy and having a score of 4 or 4 plus out of 10 in the Deleur Neuropathic 4 test, which I'm sure you're all familiar with. Exclusion criteria were previous experience with a pulsed radiofrequency current and having peripheral or spinal cord stimulator inserted in their bodies, pacemaker, metal implants, and pregnancy. The DN4 was our primary objective, and the brief pain inventory the second. Both were tested at baseline, after 3 treatments only, and 3 follow-ups at 1 month, after the last treatment, 3 and 6 months later. Each patient had 3 treatments or placebo once weekly for 10 minutes bilaterally at the sciatic nerve in the popliteal fossa. So with the primary outcome, the DN4 test is right next to us here. And you can see that we interviewed the patients. We asked 2 questions where we got 7, there were 7 yes/no answers, and we could detect various symptoms of neuropathic pain or numbness or pins and needles. And then when we examined the patient, there were another 2 questions that we could actually check by touch or pinprick or brushing. And then we would get a total of out of 10. And that would give us our score out of 10, which would give us whether there was proving that these patients had neuropathic pain. The secondary outcome was, as I say, was the brief pain inventory of 17 questions, and it included a visual analog scale and quality of life. And the results, the data were analyzed using the SAS version 9.4 statistical program, and they were expressed as mean and standard error by groups. There were differences for age and gender in these 2 groups. Age showed p-values of 0.03 and gender p-values of 0.01, and adjustments had to be made where applicable. But there were also differences of p-values evident regardless of age and gender, which really proved our point. The DN4 demonstrated that between baseline and 3 treatments, there was a reduction in pain and symptoms greater for the A group, P equals 0.03, regardless of age and gender. Between baseline and 1 month, there was a reduction in pain in both groups, but no significant difference between them, P equals 0.10, but gender and age were nearly significant, and there were no differences at 3 and 6 months. In the brief pain inventory short form, there were differences between the active and placebo groups in the worst, average, and present pain, with positive p-values, some with adjustment for age and gender. For relations with other people, there was evidence of significant changes, some regardless, and some adjusted for age and gender, and relations with other people, and without analgesics at baseline. There were no differences even after adjustments for age and gender for work and walking ability. None of the brief pain in patients' variables showed any differences when adjusting for baseline and analgesics. Oh no. Okay. So our conclusion was that after 3 treatments of PRF current, the DN4 test demonstrates significant improvements in pedal neuropathic diabetic neuropathy and symptoms in certain patients. And I believe if there were no adjustments required for age and gender, we were able to demonstrate differences in the p-values between the A and B groups, as was seen in the interim study of 34 patients. Because when we got to 34 patients, we evaluated them as well. Now, the analgesics were analyzed and included in the adjustments, but the numbers of meds taken were so varied. There were 26 different medications that patients were taking, that this was really not an accurate analysis of benefit. Therefore, in future studies of a diabetic neuropathy group, I would recommend to have even numbers of ages and gender to provide a more balanced view. And also that Only the medications that were a comparison for relief of neuropathic pain, such as Lyrica, should be considered for statistical analysis against the PRF current. But it is remarkable that only 3 short, non-invasive treatments can have such profound results on an ongoing metabolic disease. So I just wanted to show you baseline that we did start with the same numbers in the active and placebo, that the gender shows you the males to females, and the males were the larger group. And the type of diabetes, we had very few type 1, the ethnicity, the medications, there were lots more than this, and you can see the differences. And the table B shows that patients that completed the 6-month follow-up, there was 36 in the end. There was attrition, and 36 in the A group and 34 in the B group. And here we can see a nice diagram to show you the difference between the active and the placebo groups, active being the black. We've got the patients, the numbers on the vertical scale here will show us the DN4. So most patients didn't get more than 6+ for DN4. And the same goes for the placebo. But after 3 treatments, there's a big difference in the active group compared to the placebo. And here you can see the numbers, the changes after 3 treatments, and very different between the placebo and the active patients. So we got 0.03 with our p-values. And you can see 1 month later, there was still an improvement. And there was still a maintenance of improvement even by 6 months. Same with the placebo groups, but they had less. But it wasn't significant. So I think you can know, and you can tell patients when they ask you, you may see changes within 1 to 3 treatments, and it could be complete, as you're going to see in the case histories. Now, this is a very interesting case history. It was a pediatric patient. She was 9 years old, and she had long thoracic nerve palsy twice. The first attack occurred in July 2011. She fell on her shoulder, and she developed a subluxation. She didn't have much pain, but she had paralysis of her serratus anterior with severe winging, very similar to the picture that we see here. Nerve conduction studies were done, and there was 70% reduction of the right motor nerve, compared 0.4 compared with the left side, which was 2.1, and she had severely delayed latency at 5.1 compared with 3.0 on the left side. She was given physiotherapy, rehab, and exercises, and she was completely restored to normal in 6 months. So that by December 2011, she was completely normal. They did a nerve conduction test, and it went completely also back to normal, and the child continued. Then all of a sudden, in October, she had a second attack. She was holding a hula hoop, and it was a ballet lesson, and she developed the complication again, very severe winging, and she developed complex regional pain as well. It was very severe. They repeated the nerve conduction studies, and they got exactly the same results as previously. So the pain that she experienced was 10 out of 10. She has severe hyperesthesia and red discoloration from the right cervical 3-4 facet joint into the top tip of the shoulder and her upper arm. And she had very limited range of cervical rotation and no movement of the shoulder. She was unable to brush her hair, write, sleep. Arm was held by its side, and she cried continuously. We did 13 treatments, and we used NMS plus other treatments, as you can see in the treatment area. But the the overriding factor here is that the NMS seemed to have the most effectiveness because the rest of the treatment, some of it had been done before and it didn't have the same effects at all. So we did 3 treatments in October, 8 in November, so we did twice weekly, and we did 2 in December. So the treatment was only actually over a month period. So here is the treatment. Here are the dates. Started off the 25th of October, and by the 7th of January 2013, there was no need to treat her. We brought her in to see how she was doing, and I'll demonstrate how it looks. We got the number of treatments here. She was unable to, her score for the pass was 8 to 10, and it was very difficult for her to score. So actually, by the time we got to the 5th treatment, we basically stopped scoring. We also scored her VAS post-treatment. And then I just looked at the mobility. By the 5th treatment, she could actually use her arm. By the 7th treatment, she came in holding her teddy bear. And by the 10th treatment, I was able to touch her because prior to that, I could use no treatment that was liminal, that she could feel. I had to treat subliminally. But thereafter, from the 10th, I could massage her. And as you can see, 13 treatments were required. And she came back in January. That's what she looked like. That's what she'd been doing in her holiday. And that's what she used to look like. And I happened to meet her 6 years later, and she'd never had a recurrence of the condition. So if the nerve is strengthened, the nerve is strengthened for good, it seems. Then we did a report on a case series investigating a neurostimulation device for the treatment of pain and improvement of mobility and function following elbow surgery. Now, we took 7 patients who had elbow surgery. Mostly they were different types of injuries, but mainly tennis elbow. And we used Stimpod only as the only therapy to relieve acute pain post-operatively. So we did that when they were still in the splint. And I think that's a very good way to treat patients post-operatively, possibly to prevent post-operative pain. And we wanted to see if we could restore range of movement with very little requirement of treatment to improve exercise, no passive mobs or anything like that, and restore function. And so we gave 3 treatments before the splint was removed in the first 10 days. And the most beautiful area that we treated was at the brachial plexus. So we treated it superiorly above the clavicle and inferiorly below. And we'll look at that on Monday. Each patient had a total of 20 minutes treatment. Then once the splint was removed, we then did 6 treatments twice weekly, 5 minutes each, superiorly and inferiorly on the wound. And then the nerve supply just superior and inferior to the wound. So we could look at the nerve supply involved in that particular patient. So again, each patient had a total of 20 minutes. So all patients had relief of their acute pain by the 4th treatment. Then pain relief, range of movement and function was achieved by 6 of the 7 patients by the 9th treatment, adding up the first 3 and then the 6. It was maintained by most of the patients by 1 month after the last treatment, and 2 patients had to have revised surgery due in one patient to a more extensive surgery being required because he had been stabbed as well, and they were trying to repair that previously. And in the other patient, they had a fall and injured the operative site. At 3 and 6 months, all of the above parameters were maintained in the remaining 5 patients. And these patients all had excellent wound healing and were highly satisfied with their treatment. So here's your average VAS scores, and you can see that that's your VAS at the 4th treatment. And some of the patients didn't have much pain, but as they started moving it, sometimes they did get more pain. And you can see by 6 months, there was very low levels of pain. And if we look at flexion, you can see they started off with less flexion, and then they gained right up to 145 degrees of flexion. Same thing with extension there at 6 months, and even at 1 month, you can see the improvement. So it doesn't take very long to get your patients normal. And again, with active movements, we started off with the 4th treatment. And as you can see, by the 9th treatment, most patients had actually got their movement back, even before 1 month in some patients. Some patients didn't, but then they continued to improve. So the conclusion is that it appears that NMS 460 can relieve acute postoperative pain, can reduce pain over the healing period, can improve mobility and function, and stimulate wound healing, because some of those wounds were absolutely perfect. The treatment is relatively cost effective, minimal intervention, and of short duration. Now, I'm going to discuss a very unusual patient. A patient of 65 years of age was shot in the head, and some fragments of skull landed up in the brain, and he had a very dense triplegia. He was very severely affected, and I'd been treating him with a combination of treatment, which I'll show you just now, for, I would say, from October to February. And we were getting improvements all the time. But from February onwards, we started to get improvement in flaccidity. Now, that's a very important aspect, because it's well known that if the patient's flaccidity after a stroke or traumatic brain injury doesn't recover, it's not going to. But this disproves this theory. I then went on to do a review of physical modalities and the potential to expand the treatment of patients with traumatic brain injury. And there is nothing that has made as much improvement as this NMS can do. So if we look at the case history, here we've got the MRI scans. The patient, this was March 2017. He was 65 years old. Standardized outcome measures were assessed after his initial admission from his severe injury. He had extensive surgery. There's a large opening at the top of the skull where there's no skull, and it's just the brain. And he remained profoundly handicapped with complete flaccidity of that left arm, but some movement of the grasp strength it remained. So they did the Fugel-Meyer motor impairment scale with dynamometer measures, and when he came, a few weeks after he came into the hospital, he stayed in the hospital for 4 months. His grasp strength on the right hand was 26 kilograms, and he had nothing on the left hand. He had a lateral pinch of 7.5 kilograms, but nothing on the left hand, and the tip pinch on the right was 6.8 kilograms with nothing on the left. Then in July, they retested him before he left the hospital, and his grasp strength had improved in the left hand to 2.5 kilograms, and he had nothing of lateral pinch and tip pinch on the left hand beyond that, but the right hand had improved nicely. So you can see the combination. We did a stim pod on large nerve sites, and then we went right down into the radial nerve, into all the nerves that supplied the arm after treating the brachial plexus first. We did electroacupuncture and thoracic stimulation, and we treated him from October until March. And then we had a breakthrough. He was able to stand with support for 5 minutes. He wasn't able to stand before that. He was able to elevate his left arm in flexion and abduction. He can use that arm now. So the grasp strength has changed. And in the left hand, he's got 10 kilograms with the brace, 8 kilograms with no brace. Lateral pinch is 7 kilograms with no brace, and tip pinch is 6.2 kilograms with no brace. And And his progress has continued. He's now able to walk besides standing, and there's a lot, he's going to drive a car. There's so much improvement. And I think that's really something to note, which is very different from interventional pulse radio frequency. So the next patient is a neurological deficit. This patient allowed us to show you what she looked like. She was 64 years old and diagnosed with the Ramsay-Hunt disorder. She had herpes zoster or shingles affecting the right facial nerve and muscles, including her eye, mouth, nose, and tongue. Her condition commenced on the 4th of June 2015 with nil improvement after almost 3 months, with 2 courses of conventional medications and regular thoracic current ultrasound, exercise and physiotherapy treatment. And this is what she looked like. She wanted people to see the difference in herself because it was remarkable. And of course, you can imagine how embarrassing this is. She's a social worker, having to try and work this situation. So here's the number. This is what, the treatment we gave. This is the date. This is the months. This is the number of treatments we gave and how many times we treated. And we noted that when we started treating her, we could actually see activation, very little activation at the first treatment, but something was starting to happen in the treatment, stimulating various nerves, which we'll discuss on Monday evening or Monday afternoon. And she actually was able at the end of August to activate her eyebrows and have some nasal and mouth flicker. In September, we treated twice a week, and we had slight twitch in the eyebrow, movement of the nasal bridge with a frown. Then in October, her eye and mouth were much better, and she had spontaneously improved over those 2 months without treatment, and it continued without, as you see, without even active treatment. November, December, and January, she was ill and she couldn't come for treatment. But when we next saw her, there were absolutely visible improvements. And then in February, we treated her 5 times, just once a week. And in March, we treated twice. And her drooping eye was much better. She had decreased mouth asymmetry and increased muscle activation, as you can see. Oh, I'm sorry this is like this. It wasn't like this before. You can see the difference in her face and what she's able to achieve. And that is absolutely remarkable. So I'm going to show you a failed back syndrome. I'm sure you see many patients who've had many surgeries to their spine, and very often they continue to have back pain. This was a male, 72 years of age, and he had a fusion in 2005 from L3 to S1. But he developed infection in the bone, and he had due to an antibiotic-resistant bacteria, and his symptoms demonstrated evidence of spinal stenosis. So now we only saw him in 2013. So he had been continuing with a condition like this for years. So it doesn't matter how long the patient has been affected by the condition that they have. And that's a point that I wanted to make. So we only gave him 6 treatments once weekly to the 28th of February. And we used high frequency from the spinal region above and below the scar to the lateral left calf because he had severe pain in that region. And then we did NMS on L5 laterally and the left sciatic nerve, 10 minutes each, because being such a severe condition, you need to do a longer treatment. You must decide, but 5 minutes is usually good enough, but if you do longer, you may get better effects. Pain changed from 2 to 10 out of 10 to 2 to 4 out of 10. And in the past week, he had no need to lie down. He was a man that had to take a few steps, lean on something, or go and lie down every half an hour. He could hardly have a quality of life. then he only had a knife-like pain in the calf once that week for a short period. He was able to walk freely for 200 meters. There was reduced muscle spasm, and the actual tissue around the scar was soft and pliable, and he could stand upright, whereas he couldn't before. I'm sure you've seen patients like that many times. The picture will come up. It's going to take some time. There you are. I treated unilaterally as close to the facet joint as I could get. There was a lot of muscle spasm and a severely indurated scar. So let's look. We've got half an hour now, and we will have time for questions. Let's look at the application principles of therapy and procedures, the trends. We know that it relieves neuropathic pain from any etiology. It doesn't matter what the condition is, you can treat it. Usually a large reduction or nil pain by 3 treatments. It enables other aspects of the condition to be relieved with regular treatments. I'll go back to the first one, which says usually large reduction or nil pain by 3 treatments. That usually applies to conditions that have been fairly acute to subacute, I would say. They really can see some change very quickly. But once it's more chronic, it may take longer. It may take 3 to 6 treatments, that's all. It regenerates nerve tissue and it changes gene expression. So our target structure will be spinal cord, nerve root as it comes out the facet, nerve plexus, nerve branch, e.g. femoral, saphenous, or tibial. So you can travel along that particular nerve supply. I like you to think nerve. If you think about it, everything in the body depends on the brain and spinal cord and nerves. So if we fix up the nervous system, we fix up most other things. Be colloquial. So the NMS targets the nerve supply involved or responsible for the pain. The high frequency affects nerve conduction via bioelectronics, with both the magnetic field and the low frequency effects of local bioelectric effects. Cellular metabolic activity occurs, and there's an ability to change the characteristics of the upregulated firing in the nerve. So neuroremodeling occurs. The conditions that may be relieved may be pain and symptoms that may include neuropathic, neurogenic, nociceptive, or a combination. It doesn't matter. Peripherally or centrally maintained, and other conditions that may not be pain related, such as Bell's palsy, other types of palsy, neuropraxia, spasticity, and flaccidity. Some of the most difficult things to help. So it treats pain in any area of the musculoskeletal system: facial, head, cervical, thoracic, lumbar, sacral, arms, legs, joints, that may be treated by stimulating the following. As I said, the nerve supply, the muscle involved, the joint involved. For instance, a shoulder joint. Sometimes a patient will say, I've just got pain in the shoulder, but you'll treat brachial plexus, you may treat a facet joint, and then you can actually go onto the shoulder for a short treatment if it's comfortable enough. Any condition that produces pain actually may have conditions that have got neuropathic elements. We can be surprised that so often there's neuropathic elements in so many conditions that previously possibly we didn't even want to recognize because we didn't realize that it had the potential. So if it's pain in the periphery, stimulate the main nerve branch that supplies the specific nerve or the area involved. An example follows. So pain in the medial ankle is treated by stimulating one or more: the femoral nerve as it exits the groin, the saphenous nerve in either the medial thigh, knee, or medial calf, any nerve that may be involved in the ankle region. In neuropathic or complex regional pain syndrome, treat proximally or as distally as possible to prevent irritation. Very often, if you just treat at the femoral nerve for the first one treatment and you see an improvement, you may continue with that treatment And if there's not much improvement the next treatment, then you can start to move more towards the actual area. The nearest, and in the spine, the nearest nerve in the spine, above the facet joint, at the spinal region itself, you can do it just above the spinous process or just off the spinal process to try and get in, or between the spinous processes to try and get as close to the spinal cord as deep as possible, but mainly at the facet joint, as close to the facet joint. You can also do it in the muscles and any region of referral that may be identified. You can use the perineal nerve to help with patients who've got pain that's referred from the spine to the ankle. You can treat it just the same as you would a peripheral condition. So what are the conditions treated since 2009 that I've treated? So neuropathic pain and symptoms. So this would include diabetic neuropathy, peripheral neuropathy, post-chemotherapy, HIV, alcoholism, poisoning that causes neuropathies. It doesn't matter. You can still get similar effects. Complex regional pain syndromes. This is our secret weapon. When it comes to fibromyalgia, you can treat at the facet joints of the thoracic spine and also of your sympathetic nervous system. With persistent post-surgical pain syndromes, it works within 1 to 3 treatments in mastectomy and or reconstruction. And you would treat in the armpit and also in the brachial plexus and possibly further down in the arm if necessary. After herniorrhaphy, you get excellent results. You can even treat at spinal level first, and then the nerve supply that supplies L2-3, and then go towards the hernia and treat the wound. Total knee replacements are treated very well with this, and then you might treat the perineal nerve and the saphenous nerve. So you would treat like a through and through technique. The elbow surgery, sesamoidectomy, bunionectomy, excellent treatment. Post-fracture pains, then you would definitely treat a plexus far away from the area. You do not want to mobilize the fracture area. Persistent idiopathic facial pain, excellent treatment. Post-dental treatment, sometimes a patient will come after having had a tooth treated and have pain and there's nothing to see. You can actually treat the trigeminal nerve or any of the nerve branches. Headaches, including migraine, cluster, cervical spine, causing headaches. Any form of degenerative spinal disease causing referred symptoms. Failed back, chronic thoracic pain, even post-surgery, if they've had a bypass, for instance, or fractures in those areas, you can treat. Vestibular conditions creating dizziness, we would treat at the level of the second cervical vertebra, or even underneath the ear, the auricular temporal nerve. And that has profound effects on elderly patients. And it could be a good new type of treatment and also helps nausea. And for the perineum, that is such a difficult area to treat. You can treat the pudendal nerve and the tibial nerve because those areas are very much involved, especially the tibial nerve goes to the plexuses in the lower pelvis. And you can treat the vagus nerve because by treating it, it lowers blood pressure, decreases heart rate, reduces the body's response to stress, improves digestion, and possibly helps depression. So if you are interested in that, but then we do have to protect the patient. But we'll go into that on Monday. And now also you can do post-stroke spasticity and flaccidity. I do believe that if we could get these patients straight after they'd been admitted to hospital and start to treat, for instance, the plexus and the various nerve supply, you're going to get improvement. Plus, use your acupuncture as well, and the two together will give you very good results. Can be any injury, any joint pain, any stiffness, inability to void urine. That is a fascinating treatment. We treated on S2 to 4 at those levels above on the sacrum. And then we also went to the pudendal nerve and the medial tibial nerve. We had a patient that we'd been treating for other problems, and she came in and described how she couldn't pass water. We gave her one treatment on those areas, and she was able to pass water. And then she came back and said, "Oh, I've stopped." So stopped being able to pass water. So we did it again, and we only gave her 3 treatments. She's never had the problem since. So there's another field of women's health that we can help. Muscle weakness and Bell's palsy, Ramsay-Hunt syndrome, post-acoustic neuroma removal. I'm going to show you a patient next week. Damage to the facial nerve, trigeminal neuralgias, post-radiation for cancer in the mouth or throat. Meralgia paresthetica, and xerostomia from radiation. You can treat the parotid glands. You can even put the probe in the mouth. You don't need to put a gel on when you put it in the mouth because it's moist. Any compression of perineal nerve, long thoracic nerve injury, again, you saw that. And it opens up our scope of practice. Now let's look at the contraindications. The contraindications on the top: pacemaker, spinal cord stimulator, peripheral nerve stimulator, pregnancy, and metal implants. The manufacturers have put that on their website, and they've also placed this information as well. But I'm going to give you other contraindications from a physiotherapy point of view, because we use a lot of currents. So you should never use currents, a positive and a negative, on either side of the temples. When you're over the carotid arteries, the vagus nerve can be stimulated at these points, as we know, and I will show you how to do that. But you can always take the pulse or the blood pressure just to see the patient feels well whilst you're doing that. Care if other electrical therapies are applied simultaneously in close proximity to the NMS to prevent spiking of either current. And lastly, let's look at the conclusions. It assists with difficult chronic pain conditions. It can be used in acute, subacute, and chronic conditions. May prevent post-operative pain syndromes. Definitely improves wound healing. May prevent chronic pain if used early in the condition. Why don't we think of using something like this to prevent chronic pain? Chronic pain is a horrific event in patients' lives. And as a pain management specialist, I would love to see this used in hospitals routinely, even by the nurses. Once the patient has come out of the theatre, if they could have that sort of treatment, might find that the pain reduces and it doesn't allow them to have chronic pain. So blocking the pain may occur with muscle strengthening due to nerve stimulation, and often only 1 to 3 treatments are required to relieve pain permanently, expedites nerve recovery, may increase speed of nerve regeneration. And I have treated animals and seen animals treated. It has profound effects on animals with weakness due to spinal compression. So if you're a physiotherapist who does animals and has to treat patients post-operatively if they've had spinal compression with discs, you can use the StimPod on them. And that's all I have for you today. So if anybody has questions, please feel free. Can you hear me? Okay. Under what circumstances do we need? Yes. Okay, I can
That's
see
correct.
Okay. Under what circumstances do we need to change the pulse rates? Actually, I don't change the pulse rates. I've been so satisfied. I use 2 hertz, and the manufacturers also recommend 2 hertz. If you increase the pulse rate, it becomes almost like a continuous treatment, especially at 10 hertz. It vibrates continuously. And I didn't want to change the pulse rates because the results were so good on 2 hertz. I didn't need to. I hope that answers your questions. Any others? I'm glad you found it informative, and I hope you go away feeling that you really understand this device, because if you understand it, you can use it very well and with very good results. Must be a very long message you're typing here. Okay. If we would treat the sciatic nerve stimulation, on which part of the nerve would have the best treatment outcome? I think in the buttocks, in the glutes, the large part of the sciatic nerve as it comes through below the sacroiliac joint. That's where I would start if I wanted to treat the sciatic nerve. But in patients, in fact, with diabetic neuropathy, all the nerves are affected. So you could treat even in the buttock if you didn't want to treat the sciatic nerve behind in the fossa behind the knee. And it's extremely good for back pain in that position. Most patients with backache, I would, even if they had backache from L2 all the way down to S1, S2, I would treat that area. It's a very simple treatment, actually. Once you find your nerve, you will, you'll get a very good response. And you must never worry if you can't seemingly to find the nerve. If you do it anatomically from the way you've learned to identify the nerve position, and if you don't get response, something is happening, and you'll see the patient next time, and you probably will get a response. It's difficult to treat the sacral plexus. And okay, from the study you stated in the presentation, the treatment protocol seen is a mixed one. It always combines. Oh, no. The one that we did for the diabetic neuropathy was not mixed. But the one that we did with the young lady, high frequency which one is this between different pain management? Oh, well, I'm not sure which one you mean, but that must be the pediatric patient, right? So are there any studies which compares the effectiveness between different pain management modalities, such as NMS versus TENS? Well, first of all, you can't use TENS on a patient like that because it vibrates the A beta fibers that have already changed and become sensitized. So that would increase your pain. You have to know what sort of condition it is so that you can use the correct treatment. And there have been no studies that I know of. Every patient is different, and you have to get all the same patients and then do a study. That's why we took diabetic neuropathy as our treatment, as our type of treatment to compare. I think I can say that I've had a lot of experience with all the previous treatments, all the different types of current. I worked on microcurrents for years. I've used on currents that we put through the brain, very low, called alpha stim, and we clip it on the ears. I've done acupuncture in China for postgrad courses and lots of different things, and I've never seen anything like I've seen with the stim pod. I've also worked in pain clinics for many years and have traveled to the IASP meetings since 1996. And I've just never seen any of those posters that ever showed anything like this. So I think it's a game changer. This is going to make the life of a physiotherapist much easier because you don't even need to mobilize a patient's neck, for instance. If you just use the facet joint or the brachial plexus, you'll find your movements improve dramatically without you having to hurt the patient because you've always got post-treatment pain. So why should you have that with mobilizing when you can treat with this type of treatment and get lasting pain relief in very quick time, especially if you've got a lot of patients to treat. Any other thoughts that you'd like to think of, would like me to talk about? And I will just say I will just say that with that child that I had to treat, it was very difficult because everything was painful and she wouldn't bear anything. So I had to try and use so many different things. And sometimes I could only use the stim pod because it was far away from the area of the pain. So I would use it inferior to the clavicle. And very low intensity. If you've got a patient that's very sensitive, don't be afraid or think that you're not giving a treatment. You are. And a magnetic field is very powerful. And it must travel along the nerve because that's where you inserted it. So if that's got the line of least resistance, it will travel all the way along until it meets the dorsal root ganglion. But we haven't been able to prove it with anything in vivo, unfortunately. You're very welcome. And it's been a great pleasure, and I hope we can enjoy the demo on Monday. You are very welcome indeed. It's an absolute pleasure. Yes, that is the most exciting thing I've ever seen, because a life a life can be saved like that, a life of misery, not being able to hold something in the hands. And I think that it's been the happiest thing I've ever done, is to be able to give this man. And fortunately for him, he didn't have any damage to his frontal lobe. He wasn't mentally damaged at all, so we could have very in-depth conversations. He only had a right arm, a left, a right upper leg, no lower right leg, and a completely flaccid and spastic left leg. But that's improved. He can bend his knee, can raise his leg. As I say, he can stand and he can ambulate, which is my most exciting thought. And lastly, I think I'd like to say that I think you must be innovative. Think about your condition and think, where's the nerve supply for this? How can I go in and actually help this patient? What's wrong with the nerve supply that makes the condition like it is? And then you're going to be successful. Thank you very much, and you're very, very welcome. So I'm going to leave you now, I think. That's okay.